So good evening, everyone. I'm Dr. Manasi. On behalf of entire Glenmark family, I would like to welcome you for this educational initiative focused on advance on 2D eco techniques, which is in collaboration with API. This program is primarily for the HCPs who are keen to enhance their knowledges in 2D eco technique. This webinar will provide the opportunity to the audience to connecting with the leading cardiologists from the India. So we have a total 6 module, and today we are initiating with the first module, that is a echo for left ventricular and right ventricular systolic and diastolic function. Moving to the agenda, after introduction, we'll have a context setting by Dr. Shantanu Sengupta sir. After that, we will have the first session on echo for left ventricular systolic function by Dr. Mani Vasagam sir, followed by Dr. Srivastav sir will guide us on a echo for LV diastolic function. The third topic is on the echo for RV function, which is taken by Dr. Amuthan sir. Last topic is on the strain rate imaging, which will be taken by Dr. M.K. Shah sir. The closing remark will be given by Dr. Sen Gupta sir. After each talk, we will have the question and answer session. It's my pleasure to welcome Dr. Shantanu Sen Gupta sir. He is a heart failure specialist at the Sen Gupta Hospital and Research Institute, Nagpur. Sir is having specialization in HFpEF from United Kingdom. Sir is associate editor for the Cardiovascular Intravascular Society. Sir is a president-elect for Indian Academy of Echocardiography. Sir was awarded as the first cardiologist from India to present late-breaking trial at ACC. He is recognized nationally and internationally for his contribution to heart failure research and echocardiography education. Our first speaker, Dr. Mani Vasagam sir. He is a consultant cardiologist at TRP Polyclinic and Heart Care and Cure Center at Tamil Nadu. He is the president of Indian Academy of Echocardiography. Sir is associated with the different scientific organizations such as the CSI, Indian Academy of Echocardiography, and Journal of Indian Academy and Echocardiography. Sir is having numerous publications in national and international high index journal. Our next speaker, Dr. Srivastav sir. He is a principal director of the cardiology at Max Super Speciality Hospital, New Delhi. He is a member specialist committee of Ayushman Bharat scheme. Sir has been awarded as a Lifetime Achievement Award by Indian Academy of Echocardiography in 2022. Sir is also a recipient of the National Achiever Award by Z Digital in 2022. Recently, Sir has been awarded as a HFA case-based championship winner at Lisbon and Belgrade. Our next speaker, Dr. Amuthan sir, is an honorary professor at IMA National Headquarters, New Delhi. Sir is a professor of cardiology at Tamil Nadu Medical University. Sir is an interventional cardiologist at Vadmalayan Hospital, Madurai. Sir is a director of a 4D echocardiography at Jayalakshmi Heart Center, Madurai. Sir is a principal investigator for India West Normal Study. Sir has been awarded as a Lifetime Achievement Award by Tamil Nadu Cardiologist Society in last year, and Sir has been awarded as a Lifetime Achievement Award by Governor of Tamil Nadu in 2012. Our last speaker, Dr. M.K. Shah sir, is an interventional cardiologist at MK Heart Clinic, Vileparle, Mumbai. Sir is also associated with the Bharatiya Arogya Nidhi Hospital, Juhu. Sir is a vice chairman for IMA Academy of Medical Specialties. Sir is a central working committee member for IMA National Headquarters. Sir has been awarded as a Lifetime Achievement Award by Cardiological Society of Maharashtra into last year. Sir has been awarded as a Hriday Ratna Award by Times Group, and similarly, Sir has been awarded as a Lifetime Achievement Award by Government of Maharashtra. I would like to request Dr. Shantanu Sengupta sir for a context setting. Over to you, sir.
Thank you, Mansi, for such a nice, wonderful introduction for everybody. So we'd like to welcome you all for this exciting journey of echo imaging. And we, as you said, we will have 6 modules. So today being an important session where we have, as you can see, an array of international and national speakers who are of phenomenal experience. The focus will be on LV and RV, systolic and also in diastolic dysfunction, and how to assess all these things. The main important thing is this LV function assessment and RV function assessment is the cornerstone of cardiology, and it needs to be done in every patient. So I think without wasting any time, if I can request our president of Indian Academy of Echo, Dr. Mani Vasagam, to start the first topic, a very important topic of evaluation of LV systolic function by echo. And he's a master in this field. Dr. Manivasagam, please, can share your slides.
Hold on. First slide. Good evening, one and all, and respected moderator. Let me thank the Glenmark team for having given me the opportunity. Assessment of LV systolic function plays a crucial role in decision making, whether it is diagnostic, therapeutic, or prognostic. And it plays an immense role in device therapy regarding mechanical circulatory support, ICD, CRT, and so on and so forth. It gives directions to the cardiothoracic surgeons to go ahead with surgery or not to go ahead with surgery like that. And assessment can be done by conventional methods like M-mode, Doppler, pulse wave, continuous wave, tissue Doppler imaging, 2D, automatic edge detection, and 3D method. These are, if time permits, we'll go to the latest methods of assessing LV systolic function. And coming to the M-mode method, E-point septal separation is the ancient method. You go by parasternal long axis view, cut at the tip of the mitral valve. This is E and A wave. Normally, the distance between E and the inner border of the IVS is less than 6 millimeters. If it is more than 7 millimeter, it denotes LV systolic dysfunction. By the same note, you pass the M-mode cursor at the medial mitral annulus. This is equivalent to TAPSE of the right ventricle, and also put the mitral cursor, M-mode cursor over the lateral mitral annulus. You average or mean value of this can be taken as a marker of LV systolic function. Normally, it is around 12 to 15 millimeter. In this example, this is 17.5 millimeter. This is a case of LV dysfunction where the average is 7.8 millimeters. Less than 8 is denoting it is a severe LV dysfunction. Coming to our famous ejection fraction, it is as good as early as 1960. We are aware of this Tichols method by M-mode deriving ejection fraction by Tichols method. But unfortunately, by 2015 chamber guidelines, it is not recommended. These are all examples where we cut obliquely and get some other ejection fraction. We cut by anatomical M-mode, getting ejection fraction 64. We got by some of them, some of us used to get cutting at the short axis view or the papillary muscle. Inter-observer and intra-observer is very common in this Tichols method. And this is one another example where this is an anterior wall MI beyond basal septum. The short axis view gives you ejection fraction 55, and at the anterior wall where there is infarct, ejection fraction is 46. But at the baseline where there is no infarct, the ejection fraction is 69. That means in the presence of regional wall motion abnormality, in the presence of dyssynchrony, in the deformed ventricle or dilated ventricle, your ejection fraction will not be valid as a tool for a systolic function. And another case where there is an anterior wall MI and ejection fraction is 45. When you go for apical four-chamber view, by modified Simpson's method, this is an accurate assessment of ejection fraction 20%. So we cannot rely on ejection fraction obtained by Tichols method in the presence of regional wall motion abnormality. Coming to the pulse Doppler, this is one of the oldest technique. You measure the distance between the end of the A and the beginning of the E wave in the cardiac cycle. And the point A is comprises of three components. One is isovolumic contraction time, ejection time, and isovolumic relaxation time. It is not an assessment of systolic function. It is an overall cardiac function it assesses because it comprises isovolumic relaxation time. Normal value is 0.34 to 0.44. Anything more than 0.47 will be considered as a reflector of cardiac dysfunction. And you can also try this method by tissue Doppler method, where we can get all the components easily. That is isovolumic contraction time, and this is ejection time, and this is isovolumic relaxation time. And going to the continuous wave Doppler, if you have moderate to severe MR with good MR envelope like this, you can venture this MR DP-DT method. You put a dot at the 1 meter distance descending loop of the MR and dot at the 3 meter descending loop of the MR. The time interval taking this from 1 meter to 3 meter, where the pressure hikes, it can be calculated by method like dp/dt by the Bernoulli's equation. Machine will automatically give you the MR dp/dt. Normal MR dp/dt is more than 1200 millimeters per second. In this example, this is 899 millimeters of mercury per second. This denotes LV dysfunction clearly. And coming to the tissue Doppler S wave. S prime of tissue Doppler is one of the best method to assess the LV systolic function. Normally, it is more than 8 centimeters per second. If it is less than 8, in this example, 6 centimeters per second denotes LV dysfunction. When it is less than 5, it denotes very poor prognostic index of LV dysfunction. Coming to the 2D method, and this is the method you have to adapt, because you have been oriented to ejection fraction by Tichol's method, but all the guidelines support only you have to do the Simpson's modified Simpson's method if you don't have 3D echocardiography. So in this, LV is cut into different diskettes, and each one is taking at different shapes, and LV internal dimension is taken care of, and it gives you the dimension as well as volume. There, N systolic and N diastolic volume will give you ejection fraction accurately. And how to do this? You have to grab the images, apical 4-chamber and 2-chamber view, both in N diastole and N systole. N diastole, you grab the endocardial border, you trace the endocardial border in N diastole and N systole. And this is how I trace N diastolic and N systole. You switch over to the 2-chamber view, N diastolic and N systole. Machine will automatically give you the ejection fraction. And this is one of the recent versions of echocardiographic machines have this automatic edge detection technique. This is more superior than the modified Simpson's method. And this gives you ejection fraction biplane method 59. Of course, the gold standard for assessing LV systolic function is 3D ejection fraction. And latest machines getting artificial intelligence grab only one image and gives accurate ejection fraction. And you get one number by all these methods. So according to this number, we decide whether there is LV function is all right or it is reduced. According to 2015 guidelines, the normal ejection fraction guideline is 52 to 72 for male, and 57 to 57, 54 to 57 for female. And the recent universal classification of heart failure by ejection fraction gives you this classification by 2021. Heart failure with a reduced ejection fraction equal to less than 40, mildly reduced ejection fraction 41 to 49, preserved ejection fraction equal to more than 50%. They have included improved ejection fraction from the baseline of less than 40. If there is significant improvement in the sequential echocardiogram, we can label it as improved ejection fraction. And what is the normal ejection fraction? None of the guidelines are so far given us. And one of the latest British Society of Echocardiography gives is if it is more than 55 and it is less than 65, we call it as a normal ejection fraction, more than 55 to 65, like that. And we know now the limitations of ejection fraction as a marker of LV systolic function. This is Tom Marwick group explanation. This is physiological limitations, load dependent, difficult in high and lower heart rates, and small LV tends to overestimate ejection fraction. Technical considerations regarding this: image quality is more important, geometry dependent, jerky IVS movement, post-operative or left bundle branch block, paradoxical septal movement, all these things, your ejection fraction will be abnormal. Clinical consideration: when the ejection fraction is less than 50, it has got prognostic impact. When it is ejection fraction 50 and above, the ejection fraction loses its capacity as a prognostic index. So we need to have an alternate good marker for assessing LV systolic function, that is 2D strain imaging. It is less operator independent, less inter and intra-observer variability, less load dependent, advantage in sequential follow-up of various cases. And moreover, this is the advantage of 2D strain imaging. That is the second marker of systolic dysfunction assessment. This can detect subclinical LV dysfunction. What is that subclinical LV dysfunction? You all know about the stages of heart failure. Stage A, patient with risk factors, asymptomatic, structurally normal heart, normal biomarkers. Stage B, patient has asymptomatic stage, but structurally abnormal heart, patient has biomarker elevation. Stage C, this is the stage of ejection fraction fall and patient becomes symptomatic. The pre-heart stage to symptomatic B to C, there is a time lag of 5 to 8 years. This is 2D strain by global longitudinal strain can pick up the structural damage well in advance before the ejection fraction falls. That means this has got greater tool and greater edge towards identifying the structural heart disease. That is why we follow global longitudinal strain. And this is the longitudinal strain. This is subendocardially put endocardial fibers. This is radial strain. This is circumferential strain, so on and so forth. And this is the example of AFI or 2D strain. It gives you ejection fraction at the same time global longitudinal strain. In this case, this is 22. Normally, more than minus 18 is considered to be normal. Less than minus 16 is considered to be abnormal. Your day-to-day practice, this is concentric LV hypertrophy of a hypertensive heart disease. Ejection fraction by all the three methods are normal. Again, in this method, 2D strain method also, this is 59 ejection fraction. But unfortunately, global longitudinal strain is less than 16. That means this hypertensive patient, in spite of normal ejection fraction, has got subclinical LV dysfunction. Your bread and butter daily is diabetic heart. This is an example of ejection fraction by all the three methods, and the ejection fraction is absolutely normal, but this patient has got subclinical LV dysfunction. If you don't do this global longitudinal strain method, you will be treating only insulin and OHA for diabetes, but unfortunately patient will at one point of time will land up in diabetic cardiomyopathy. If you pick up this subclinical LV dysfunction, you can pick up these diabetic individuals and treat them properly. And final is, this is chemotherapy related cardiac dysfunction. This is prior to taking doxorubicin. This is the basal echo. Ejection fraction is 78. This is 3 weeks after ejection fraction is 78. Prior to chemo, 64. After chemo, 62. No significant difference in ejection fraction. But when you do global longitudinal strain, prior to doxorubicin, this is 21.6. And after 3 weeks, it has fallen down by 4.2 by absolute method, by 19.2% fall in relative risk reduction, relative reduction. What is the significance of relative drop? When the relative drop is more than 15, we have to stop the chemo and switch over to some other drug, or we have to restart the chemo with a lesser dose, or we have to restart the chemo with the cardioprotective agents like beta blocker, ARBS, or ACE, etc., which will protect the heart. So 2D strain is also has got certain limitations. Frame rates are there. Irregular rhythm, we cannot do it. It is less but still load dependent. Foreshortening will increase the strain values and so on and so forth. Now we are moving to the third systolic marker that is called myocardial work imaging. What is the myocardial work imaging? When you are well versed with global longitudinal strain, you can get three extra points, extra things. One is post-systolic index. This can be helpful in coronary artery disease, and peak systolic dispersion, which can tell you sudden arrhythmic arrest, sudden cardiac death, and it can give you a surrogate marker of LV fibrosis, peak systolic dispersion. Thirdly, this is pressure strain loop we can get from GLS. How do you get this? You get PSS, that is global longitudinal strain. You get the image like this. Then you measure or input to the machine brachial artery systolic and diastolic pressure. After time intervals, this machine will automatically give you pressure strain loop. And after this pressure strain loop, this will give you various 4 components. This is called global work index, global constructive work. These two are suggestive of systolic, marker of systolic. Global constructive work is otherwise known as, it reflects contractile reserve of the myocardium. This is a powerful tool. One of the advantages is this is load independent measure. Ejection fraction and global longitudinal strain, these two measures are load dependent, whereas this myocardial work is load independent. This is wasted work and work efficiency. You will be soon hearing all those things in recently. So the work is going on. This is the third systolic marker. And the take-home message, if your endocardial border is very clear and your 2D echo is very clear, you can go ahead with modified Simpson's technique. If your images are very poor quality, then you go for tissue Doppler. In spite of poor image quality, tissue Doppler S prime wave will give you definitely some idea about the systolic function. Thank you very much.
Thank you so much, Dr. Manivasakam, for giving an overview of assessment of LV systolic function. It was good, but I think we have some interesting questions. So the one question is, how do you approach borderline LV ejection fraction?
Pardon?
50 to 55 in asymptomatic patients.
50 to 55.
In asymptomatic patients.
Symptom 50 to 55, even though they say it is preserved ejection fraction, current guideline says less than 55 is still, it is considered to be impaired ejection fraction. Only normal ejection fraction is 55 to 65. More than 65, again we have got one more phenotype that is called supranormal ejection fraction. If your ejection fraction is 50 to 55, still it is impaired ejection fraction. All your drugs, ARNI or ARBs and beta blockers and aldosterone and antagonistic, all these things will still work when the ejection fraction is less than 55. When it is more than 55, all these humoral modulators will not work. The only drug that will work beyond 55 up to 65 to 70 is SGLT2 inhibitor.
Great, perfect. So, second question, variation of ejection fraction in MR and AR in early stages and late stages.
Variation of ejection fraction.
Yeah,
exactly. To start with, there will be hyperdynamic circulation. Naturally, you will get an the ejection fraction will be near normal or supranormal. As the days go on, contractile dysfunction, if it occurs, in spite of severe MR or AR, your ejection fraction will fall. Definitely. In the late stages, ejection fraction will fall. When the contractile compensatory mechanisms fail, your ejection fraction will fall.
Absolutely. And one more last. So whenever we are assessing systolic function in valvular heart disease,
yes,
for example, can we use MAPSE and TDI for assessment of LV function, especially in MSAS due to rheumatic heart disease?
Which one you say, Max?
In valvular heart disease, for
yes,
assessment, do you use MAPSE or TDI?
MAPSE, it is prohibited because of the valvular dysfunction, because of the medial mitral and lateral mitral annulus. When it is calcified, it will not work. Usually in the valvular heart disease, that is mitral valve disease, when the valve is absolutely normal, then you can to some extent rely on this finding. When it is severe fibrosis, when there is calcific valve, MAPC cannot be applied. Or in the prosthetic valve also, MAPC cannot be applied.
Absolutely. Very valid points. So I think, Mansi, can we have the question? You wanted to give it to the audience, some audience poll you had?
Raksha, can you please
Yes,
project
Dr.
the
Mansi,
result?
we can show that poll in the last.
Acha,
Okay,
okay.
but any more questions from the audience, or we move on to the?
Sir, as of now, we have just like 3 questions only. So
So I
after
think
next
Dr.
session,
Manivasigam, it was very nice. I mean, you gave an overview of the whole LV systolic assessment. One just last question from my side. So, do you advise doing an M mode usage for assessing EF? Because we see a lot of M modes
See,
still.
that's why in the initial remark I already mentioned, after 2015 chamber guideline, we are discouraging getting ejection fraction from Tichol's method or any M mode method, as per the 2015
Right.
guidelines. But still patients, I mean, our friends are doing till today. But that is why I insist on a modified Simpson's method, at least learn from today itself. This will give you in the long run some sort of reliable ejection fraction. Those who
Yeah,
do
so,
not have 3D ejection fraction.
So, which method of EF calculation should be considered before CRT?
CRT.
Yeah.
CRT, we do, but automatic edge detection I used to measure regularly and give. That is more reliable, because in the presence of jerky IVS movement, your Tichol's method is not at all valid. You can take modified Simpson's or 3D method for assessing ejection fraction for CRT.
Absolutely correct. So I think that the take-home message is that the biplane Simpson is a robust marker and has got a better reproducibility. And also, it is mandatory to have an ECG gating in all echo being done from now onwards.
Absolutely, absolutely.
It is very important. Thank you, Dr. Manivasagam, for a nice
Thank you,
talk.
thank you.
So, should we go to the next talk?
yes, sir. So I would like to request Dr. Srivastav, sir, for his present.
Yes, sir.
Sir, he's going to speak on assessment of LV diastology, a very important topic.
Thank you very much. I just hope I'm audible. My greetings from 48 degrees centigrade without current.
48 like.
And my inverter probably will get put off in between the talk, but I'm not that unlucky. Let's start. So this is my topic of the day today. I have to talk about assessment of diastolic dysfunction by echocardiography. So these are the topics under which I'm going to talk about the topic this evening: physiology, epidemiology, what is the definition, etiology, and what are the present guidelines and the newer concepts. So by definition, it is defined as an inability of left ventricle to attain a normal end diastolic volume without an inappropriate increase in LV end diastolic pressure. Now, that means your end diastolic pressure is higher and there is an end diastolic volume which is normal. That means it's a small heart with increased end diastolic pressures. This is what the diastolic dysfunction is all about. Now, where are we? It accounts for about 50% cases of heart failure, which is an unrecognized clinical entity till very recently. The features of REF versus PEF, that means heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction, is exactly the same. The signs and symptoms are exactly the same. Though we see this PEF more in women, it is associated with hypertension, diabetes, dyslipidemia, and atrial fibrillation like REF. And patients with heart failure with preserved ejection fraction in few studies have been found to have worse prognosis than with BEF. So this is the definition, clinical definition in 2012. Nothing much has changed. The symptoms are typical of heart failure. Signs are typical of heart failure. Normal or only mildly reduced ejection fraction, and LV is not dilated. So LV is small with high end diastolic pressure. Relevant structural heart disease is in form of LV hypertrophy, LA enlargement, and or diastolic dysfunction. So the current changes as they have been mentioned is A, the first 2 points continue to be the same clinical signs and symptoms of heart failure. There is evidence of preserved or normal ejection fraction, evidence of abnormal LV diastolic dysfunction that can be determined by Doppler echocardiography or cardiac catheterization. This is something which is a little bit of a change from the earlier concept, which is nothing very great. So physiologically, ventricle has two alternating functions. One is systolic and diastolic. Diastolic can be divided into 4 phases. I'm just quickly going through the revision so that we don't miss out on anything. First phase is isovolumic relaxation phase, when there is only electrical activity, but the volumes are exactly same. There is early rapid diastolic filling. That means the LV is dilating and it is sucking blood from the LA. There is a phase of diastasis where there is no activity at all of the volumes. And last is the atrial kick. So these are 4 phases of physiology. Now, when it comes to LA, which is actually a marker of diastolic dysfunction by and large, LA functions in different manner in different phases of cardiac cycle. During systole, which systole? Ventricular systole. During ventricular systole, LA is dilating because LA and LV contract differentially. When LA is contracting, the LV is dilating. When LV is contracting, LA is dilating. So during systole, LA functions as a reservoir. It is filling up. Then during early diastole is IVRT and E wave. It acts like a conduit. That means it just the LA and LV, they continue to be the same and it acts like a conduit. But during late diastole, what is late diastole? Late diastole is A contraction, atrial contraction. The moment there is an atrial contraction, this acts like a pump. So LA has 3 functions as we can see in different phases of cardiac cycle. During systole, it works as a reservoir. During early diastole, it is a conduit. And third, during late diastole, it is a pump. Not going into the details of this, but if you look at the right side of the right half, rapid filling is E wave, phase of diastasis is stasis, atrial contribution, and whatever these hemodynamics are happening, the Doppler translates very reciprocally, but delayed. Time-wise, it is a little delayed as it when it comes to the volume versus velocity. So velocities appear a little shade later than the volume changes. So what are the determinants of diastolic dysfunction? Ventricular relaxation and compliance, LA volume and function, heart rate and pericardium. And derangement of any of these will lead to abnormal filling pressures and diastolic function. So remember, we are talking about normal sizes, increased pressure, normal size of LV and increased pressure. So these are the hemodynamic variables of LV and diastolic dysfunction. It's a little busy slide, but when it comes to LV relaxation, you have to look at the E prime. When it comes to LV stiffness, you have to look at E to A by A ratio, E to E prime, E to somebody else is talking about the strain rate. I'm not going to detail too much about it. And LA strain and LV strains are the ones which you have to look at when you're talking about LV stiffness. And when it comes to early diastolic recoil, then it is by the E prime that you talk about it. So in early diastolic filling, it is affected by preload. That means whatever is being received, transmitral volume flow rate and atrial pressure. Late diastolic filling is affected by cardiac rhythm, atrial contractile function, and ventricular end diastolic pressure. So sum and substance of what I'm talking about is this. When it comes to diastole, the early phase is the suction and the late phase is push from the LA. So these are the etiological problems, as we can see in any diastolic dysfunction. So when you look at the temporal profile, diastole is first to go, especially during the ischemic cascade. If you look at the ischemic cascade, the first thing to appear is the acidosis in the coronary sinus. So this was a study where a dog's artery, left artery descending, was tied up, and people saw which were the changes. The first thing which happened was there was a acidosis in the coronary sinus. Then what they found was that there was a perfusion defect by the, as was mentioned by the myocardial perfusion imaging. Third was there was a diastolic dysfunction. Fourth was systolic dysfunction, regional wall motion abnormality. And last was ECG changes and pain. So in the ischemic cascade, diastole occurs rather early, and clinically, this is probably first to go. So this can happen in primary myocardial disease like dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy, hypertension, secondary hypertrophy in aortic stenosis, congenital heart disease, coronary artery disease, extrinsic patterns like pericardial tamponade or pericardial constriction. Everything can have diastolic dysfunction. Classification wise, mild dysfunction is whenever there is an impaired relaxation with normal filling pressure, grade 1. Same impaired relaxation with mildly increased filling pressures, grade 1A. Moderate is when you have a pseudo-normalization of mitral inflow pattern. 3 is reversible restriction, that means high filling pressures, and 4 is irreversible. How do you define reversible versus irreversible? Is if you look at these columns will have, the first one is mitral inflow, second is with Valsalva, and third is tissue Doppler imaging and pulmonary veins. So it is important that when you have to talk about reversible versus irreversible, you need to do some maneuvers like Valsalva so that you find that the restrictive phase is whether reversible or irreversible. In irreversible phase, the A is not going to change too much as compared to E. However, when you do a Valsalva, and similarly, when you have to rule out a problem with normal versus pseudo-normal, Valsalva strain really helps you that time. So echo assessment of diastolic dysfunction is exactly like non-invasive Swan-Ganz catheter. It gives you reasonably good idea, and what you need to do is you have to have a Doppler, M-mode, and some new modalities. How do you assess it? You have to have anatomic correlates, and you have to have a functional correlates. The functional ones are the ones which we are going to talk more about it, because anatomy is rather well understood. So when it comes to anatomy, you have to look at the LV mass and dimensions. LV hypertrophy is the commonest cause of diastolic dysfunction, and there is a relative wall thickness, and LA volume and LA volume index have to be calculated. LA volume index is a very interesting parameter, and much work has been done, and Shantanu is a pioneer, at least in our country, to have worked maximally on the LA volume index, especially in our athletes. Correct me if I'm wrong, Shantanu, but you have been really a pioneer in all these things. So LA volume index, if it is greater than 34 ml per meter square, it is independent predictor of death, heart failure, atrial fibrillation, and ischemic stroke. And LA volume actually is something like an HbA1c of heart failure, especially for the PEF, or the preserved ejection fraction heart failure. The limitation is that dilated LA can be there in bradycardia, anemia, other high output failure, atrial flutter, fibrillation, and significant mitral valve disease. How do you record the mitral inflow is very important. Apical 4-chamber, put pulse wave. And where should be the pulse wave? It should be 1 to 3 millimeter sample volume between mitral valve tips. The sample volume should be small in between the two tips of AML and PML. Initially obtain a sweep at the speed of 20 to 50 for the evaluation of respiratory variation. And if variation is not present, then the sweep speed is increased to 100 at end expiration and average it over 3 cardiac cycles. This is how you do it. And if you look at this, there is one little bump here in between E and A. I'll talk in a while about this. This is the L wave. Again, problem with L wave is that there are a lot of reasons which have been attributed why L wave is there. But in case the L wave is there, then if it is velocity is more than 20, then take it for granted that the LVDP is raised. So these are certain hemodynamics comparisons. Not to go too much into details about it, we know that when you're talking about transmitral flow velocities, you have to calculate the deceleration time, you have to calculate the E, you have to calculate the A and IVRT, which is isovolumic relaxation time. So these are the parameters which you have to measure. And the secondary measurements you have to take is mitral A wave duration. You can take the A wave velocity time integral, and you can take the mid-diastolic flow, which is L wave. So this is a little bit about L wave, which we see so often and completely ignore. It's a distinct forward velocity flow after the E wave with a peak velocity more than 20. And it's a marker of advanced diastolic dysfunction, delayed and prolonged LV relaxation, increased LA pressure, and the effect of Valsalva and leg elevation can exaggerate mitral LV or reduce it. What happens in Valsalva is the moment you are in the strain phase, your preload reduces. When your preload reduces, your LVDP reduces, your LA pressures reduce. So whatever are the effects, so your pseudo-normal pattern, in case it's there, will get converted into A more than E. So that is how it works. This is the mitral L wave, as you can see it in between E and A. Then what you do is mitral inflow and annular tissue Doppler you need to do. So E prime has to be calculated septal and lateral. Most of the times the mitral lateral E prime is a little higher than the mitral medial. So lateral is a little higher than medial, and this is how it is. Here is an example of a 35 years old boy, hypertension with some kind of an LVH. So what you have done is you have taken the tissue Dopplers. This is again pulmonary venous flows. So pulmonary venous flows have gone a little out of fashion currently because it's little difficult to do and even more difficult to interpret. IVRT is a time interval between aortic valve closure and mitral valve opening. It is approximately 80 to 100 milliseconds. Impaired relaxation is associated with prolonged IVRT, and decreased compliance and elevated filling pressures is associated with shortened IVRT. So it is useful in determining severity of diastolic dysfunction, especially in serial studies of patients on medical therapy or with disease progression. Here is how it has to be done. The limitation of mitral inflow measurements is it can't be done too well in sinus tachycardia, conduction system, and arrhythmia, especially if you have heart blocks, which can completely result in silliness of evaluation. And many a times with problems of tachycardia also, you can have E and A merged together, which is known as single mitral inflow pattern, and then you can't really make any sense of the deceleration time. But what you can still continue to measure is IVRD. Another limitation is atrial flutter and AV blocks, and PA pressures can be calculated with Doppler tricuspid regurgitation and PR. Multiple atrial filling waves are seen with diastolic mitral regurgitation, so it becomes a little bit of a challenge when it comes to mitral inflow measurements, and these are things you have to do. Now, Valsalva maneuver, I have told you something about it, but what it means is, if you look at the second bullet, it says because the Valsalva maneuver decreases preload during the strain phase, pseudo-normal mitral inflow changes to a pattern of impaired relaxation. That means impaired relaxation is A more than E. So this is an importance of Valsalva maneuver. Then you have to do some quantitative analysis, and these quantitative analysis are done in tissue Doppler acquisition. Now, there are four things which currently have been the focus in diastology. One is E prime, second is E2 E prime, third is LA volume index, and fourth is have I missed something? E2 E prime and TR jet velocity. So these are four things which we are talking about, and the simple way to remember is the table of 7. 7 ones are 7, 7 twos are 14, 7 threes are 21, 7 fours are 28, 7 fives are 35. So 7 ones are 7. E prime, if it is lesser than 7, I'm upset about it. 7 twos are 14. E2 E prime, if it is more than 14, I'm upset. Say 15. Okay. 7 threes are 21, forget about it. 7 fours are 20. 7 fours are 28. So your tricuspid jet velocity should be lesser than 2.8, 28. And lastly, LA volume index, 7 fives are 35. So it is roughly 34. So this is how I have remembered my diastology, and this just about sums up whatever we are doing. Now I'm talking about the E2 E prime. It is not accurate as an index of filling pressure in normal subjects or in patients with heavy annular calcification. Somebody had asked this question earlier. So here is the answer. For heavy annular calcification, mitral valve disease, and constrictive pericarditis, E2 E prime doesn't stand. E prime, somebody is going to talk about it, but take a early diastolic filling pressure, cutoff is 7 or 8. Less than 8 is upsetting. Filling velocity after atrial contraction is A prime, E prime to A prime. People have calculated all sorts of ratios, but the most robust is E to E prime. Why? Because in this E to E prime, you have objectivity. If it is less than 8 versus more than 15, these are 8 to 15 is a gray zone where you have to do some more jugglery to come to a conclusion whether it is really myocardial diastolic dysfunction or not. Here is the correct placement for tissue Doppler imaging. So you calculate E prime and A prime. Medial versus lateral, again, you have a little bit of a difference, but most people think that averaging the two is good enough. Talked about E to E prime ratio, less than 8 is usually associated with normal LV filling pressures. More than 15 is bad. 8 to 15 do some more jugglery. So normal EFs, lateral tissue Doppler signals, have the best correlation with LV filling pressures and invasive indices of LV stiffness. So then there is a time interval between E to E prime. Again, it has its own limitation, but this is something which can be used just in case your E to E prime falls in between 8 to 15. And this ratio, if has a reasonable accuracy in identifying patient with. So here is PCWP versus E to E prime. PCWP to E to E prime. Enough and more studies have been done to find out whether this wedge pressure is directly proportional to E to E prime, though this is not sacrosanct. So if your E to E prime is more than 15, then your pulmonary capillary wedge pressure is roughly more than 20. So LA pressures is high, and E prime is from the medial annulus, or more than 12 E prime from lateral annulus. So the ratio changes just because there's a little bit of a difference between E prime, which is from lateral versus medial annulus. We've talked enough about it. It is the most reproducible echo parameters, but it has its own limitations. And it cannot be done in certain conditions, like I've already told, mitral annular calcification, mitral valve disease, rheumatic heart disease, etc. But it has a prognostic indication as well, and it is reasonably good for pulmonary capillary wedge pressure. Pulmonary venous flows, sample volume bit, again, it should be a little small, 2 to 3 millimeters sample volume, more than 0.5 centimeter into the pulmonary vein. The filter setting should be such that you can get the A reversals, sweep speed of 50 to 100. Now, this is AR duration is important because when you compare it with A versus AR, if the difference is between 30 milliseconds, then it is predictor of a high pulmonary end-diastolic pressure, pulmonary artery end-diastolic pressure. So you take the peak systolic velocity, peak diastolic velocities, AR, but most important, I'll quickly come into this a little later, but let me talk about acquisition of pulmonary M-mode flow propagation velocity. This is measured as the slope of first aliasing velocity during early filling from the mitral, and it is measured from mitral valve plane 4 centimeter distally into the LV cavity. If your propagation velocity is more than 50, it is considered normal. So here is an example. More vertical it is, better it is. So this is how it would look from a patient who has a depressed ejection fraction. And next one will show you a sequence of, from left to right, increasing diastolic dysfunction. So more vertical it is, better it is, and more horizontal it is worse off. And this is considered to be one of the features where you have atrial fibrillation, when you have 2:1 block, when you have first-degree heart block. This is something which you can use. Now, diastolic stress test is something which the world has been doing. In this, you do a supine bicycle or treadmill protocol and calculate the E to E prime, TR jet velocity, and this is how it is. It hasn't taken off in a big manner because all of us do it, but we really don't know how much sense to make of it, because actually what we are doing in stress test most of the times is trying to find out regional wall motion abnormality worsening. The role of a dobutamine is extremely controversial and not to be established, because dobutamine is an inodilator, and inodilators will always mess up with your preloads, and inodilators will always mess up with your afterload. The only thing which dobutamine does is heart rate. So this inodilator will always have some ambiguity for assessments. This is something in atrial fibrillation, and let me not confuse you because I think I'm overboarding on my time. Here is what I said, that you take a pulmonary vein A duration and mitral wave A duration. In case the difference is more than 30, it means there is an elevated LVEDP. And if your A wave reversal velocity is greater than 30, then again, it is a sign of elevated LVEDP. These are certain more parameters. People, you keep reading about all this and you will keep getting more and more confused. These are the recent indices of diastolic dysfunction. Again, these are some things which you can pick up from the book. If you want, I can send my talk to Khushbu, which I've already done. She can share it with you. But these are the guidelines in which we have to follow how to do it. Let me just give you a sum and substance of what to do. So this is the one which I was talking about. So there are 4 parameters which you have to check. You have to check the E prime, you have to check E to E prime, you have to check TR jet velocity, and you have to check LA volume index. If the less than 2 are there, no diastolic dysfunction. More than 2 are there, certainly there is a diastolic dysfunction. Problem comes with intermediate, which is 2. So 2 out of 4, when it is there, then you have to keep measuring other parameters and come to some sense of it. And then you start looking at the E to E prime ratio, you start looking at E velocity, you start looking at IVRT, and then when you again keep filtering it out, when your numbers are more one way or the other, you start labeling it as a diastolic dysfunction. Okay, so lastly, I have confused you enough, but whenever there is a confusion, so E to E prime less than 8, E to E prime more than 15, 8 to 15 is the gray zone. You start doing more things, but many a times you would still be upset and you would not know whether you're dealing with diastolic dysfunction or not. Look at the 2D anatomy. Thickened LV, assume everything is LA dilated, assume it is diastolic dysfunction. Still, if you are confused, don't hesitate to utilize other imaging techniques and be shameless to use biomarkers like NT-proBNP. Thank you very much for a patient listening. I'll stop sharing and take the questions in case there are any.
Thank you, Dr. Srivastav, for a very elusive topic discussion on this important topic of diastology. A couple of questions. If EF is less than 55, then do we need to start treatment if the patient is asthmatic on routine checkup?
Very interesting. Somebody had already asked this question. Now, which are the conditions where patient's ejection fraction falls and you are sure that he is normal? This is more often than not found in high intensity athletes. And if you look at this, you find that the LV is kind of beta blocked because this is what the vagus does. This is what parasympathetic does. And you're not sure what to do. What you have to do is call the patient again after stopping his exercise for 3 days. Reassess. You will invariably and always find that the ejection fraction is improved. There is no sacrosanct. Now, what is the cutoff? Cutoff is 57%. Less than 57%, women and people with ejection fraction less than 57% have been found to benefit with ARNI. Certainly, SGLT2 is better across the board, but when it comes to ARNI, they have been. Try to find out. So when you are given a cutoff that this is the cutoff for ejection fraction, this is not sacrosanct for an individual. These are individualistic things. Please, if there's somebody who's going for a jog like Shantanu, you do his echo, probably you will find that his ejection fraction will be 50%. He is a regular marathon runner. Ask him to stop for 3 days and then do it before jumping to put the person on SGLT2.
I think very valid point. So continuation of that, how can we determine a patient of HFrEF, whether he needs an ARNI or ACE inhibitor?
So most of the places where ACE inhibitors are indicated compared to ARNI are the ones where ACE inhibitors are cheaper than ARNI. Otherwise, there is no question, no debate. ARNIs are to be preferred over ACE inhibitors, full stop. Except there are countries like UK where ACE inhibitors are much cheaper compared to ARNI, and that is the reason. In our country, that is not the truth, because in our country, ARNI is probably as cheap as ACE inhibitors.
Yeah. So one more important question. Apart from 2D echo, in which condition radioisotope scans are indicated? And if so, then what are all the radioisotope scans available now?
Apart from 2D echo, in which condition radioisotope scans are indicated?
Yeah. So
what are
radioisotopes can be used? And if yes, where are they indicated? And if they're available, what are these scans available?
Okay, so radioisotopes, let's talk about the commonest. Commonest is myocardial perfusion imaging. Conventionally, it was thallium which was used, but these days what they use is dual isotope. And technetium is something which is done well. Now, this is for myocardial perfusion imaging, where you make the patient sit down, give the tracer, scan it, make the person run. If the propensity of this radioisotope is to go and get deposited into all the segments of the heart where the blood supply is good, Now what you're doing is you are making the patient walk, you raise up the heart rate. So you are deliberately creating a myocardial supply-demand mismatch, and then you inject the tracer again and you see whether there is a cold spot. So this cold spot gives you two reasons, two answers. One is the area of risk and the intensity of ischemia. One. Second is special tracers when you have a high index of suspicion. Say if you are suspecting there is a person who has got heart blocks, there is a person in that same heart blocks, he has got VT, you do an echo and you find that there is a non-arterial segmental wall motion abnormality. What is this non-arterial segmental wall motion abnormality? Mid-septum is showing akinesia. That's it. First degree heart block, Vanky-Backs, VT. Now, what are we looking at? We are looking at sarcoid. So whenever you are looking at sarcoidosis or suspecting sarcoidosis, you do an FDG scan. This will pick up inflammation. Third are specialized. Low pressure tricuspid regurgitation, thickened tricuspid valve. The valve is tethered to the RV. There is severe tricuspid regurgitation, low tricuspid valve, no history of trauma. And what are you looking at? You're looking at carcinoid. So there is yet another scan called, which is known as a Daytonic scan. And this is specifically used for nothing but NEDs, which is the neuroendocrinal tumors. So there are several things, and this you have to discuss it out on high index of suspicion for what. In case you are suspecting hypertrophic cardiomyopathy, MRI becomes a better tool. If you're suspecting sarcoid, do an FDG scan. If you're suspecting carcinoid, do a Daytonic scan. If you are suspecting ischemic cardiomyopathy, do a regular technician scan.
Perfect. I think these are very broad things, and it can have one more discussion about these radioactive scans. So, whenever you're assessing diastolic dysfunction for valvular heart disease, especially MS-AS, what is your approach?
Why should I assess diastolic dysfunction in MS? Basically, MS is mitral stenosis is something where I have no business to assess diastolic dysfunction. My heart failure, I know symptoms are because of mitral stenosis. My signs and symptoms are because of mitral stenosis. I know there is no overload of LV. In mitral stenosis, LV is not overloaded. So where is the question of assessing? So assess diastolic dysfunction only when the place is determined, when you have no other reason except, so structural heart disease. And which is the other thing? What should be the
Aortic stenosis. AS.
Yes. So again, in AS, you don't have to assess because you know that the symptoms are because of aortic stenosis. Yes. What should you assess in aortic stenosis? Should you assess the LVDP? No, it is raised. You have to have, this is a usual sequence. It is not a disease per se. So whenever you have to assess diastolic dysfunction, assess it in absence of a significant structural heart disease, which prevents the LVDP from going up high. What is important in AS is do a very nice aortic stenosis tissue Doppler, because good about 20% of patients, 1 in 8 for sure, 1 in 5, some studies have said, will be associated with amyloidosis. That is the reason why tissue Doppler should be done in all aortic stenosis, not to assess the diastolic dysfunction. It is a sequence. It is a sequelae of aortic stenosis to have a diastolic dysfunction, but to assess whether post valve replacement there will be an improvement or not, because if it is associated with amyloidosis, you will have a poorer outcome.
Perfect. So, Dr. Srivastav, amazing talk, but I would like to just comment that there is a very nice recent paper on diastolic dysfunction assessment beyond the routine, especially in valvular heart disease in Lancet. and that comes from my brother Partho. So I think if anybody is interested in reading diastolic assessment in valvular heart disease, you should read Lancet paper. So I think let me thank Dr. Srivastav. Amazing discussion on a very important topic, which I'm sure you can discuss for 2 days because diastology is still an enigma. A lot of things are there, but I think whatever he told about the 4 parameters of E prime, E by E prime, TR velocity, and LA volume index should be routinely done to make a good identification of HFpEF and diastolic dysfunction. Thank you, Dr. Srivastav. Let's move on to the next speaker. If I can have Dr.
Amuthan.
Amuthan.
Yeah.
And he's going to talk about a very important chamber, RV. Assessment of right ventricle. It is not yet, no more neglected. So over to you, Dr. Amuthan, please.
Are my slides visible?
Yes, sir. You
Yes.
Can, yes.
First of all, thank our IAE Scientific Chairman and President-elect, Dr. Shantanu, and Gladmark people who have organized this joint session with Association of Physicians of India. Now, RV function assessment by echocardiography is one of the major topics. And, RV is considered as a forgotten ventricle. That is because during routine examinations, we emphasize so much on LV that we forget RV. Now, coming to the anatomy of RV, RV has 3 portions. One is the inlet portion, comprising of tricuspid valve and subvalvular apparatus, and the trabeculated apical portion and the infundibulum. So, all the more, these make the RV a difficult chamber for assessment. Now, the importance of RV function cannot be overemphasized in patients with congenital heart disease. Routinely, RV function has to be measured in these patients. And in acute heart disease, in patients with ischemic heart disease, ventricular failure, pulmonary hypertension, and post-heart transplant, RV dysfunction has to be assessed. Now, why? Echocardiography is cheap, quick, accessible, non-invasive, and no radiation exposure is involved. So, routinely you do this. Now, this is the protocol to be followed. First of all, have an assessment of RV dimensions. Simple way is if the RV size is more than 0.5 or half of the size of LV, then you have to do the complete RV assessment. You go for TAPSE, TASP, TI index, LA index, then go for the strain and 3D analysis. This is the routine things which you have to do. TAPSE is tricuspid annular plane systolic exertion. TASP is tricuspid annular systolic velocity. T index is myocardial performance assessment. LE index is LV eccentricity index. Now, these are the 2 recent guidelines. So, this is the echo research and practice where British Society of Echocardiography have given their guidelines. This is 2020, and this is the guidelines by American Society of Echocardiography, recently published in 2025. Now, enormous attention I have emphasized that has been given to left heart, and lack of familiarity with the ultrasound techniques for RV. So, this is the cause for scarcity of normal reference values in RV and RV routine RV functions. Now, how do you look at RV? These are the classical views, all of you know, and the parasternal long axis, short axis, RV inflow and RV outflow views, and RV focused apical 4-chamber view and RA focused 4-chamber view. Now, how do you get RV focused apical 4-chamber view is, this is the conventional Now, this is the conventional apex, and you can see here, you have to go little above and then point towards anteriorly and interior towards this. So that is how you do the RV focused apical four chamber view, and this is slightly modified to get RA focused. This is the RA focused apical four chamber view. So these are the basic views which are available, and these are the segmental nomenclature for RV valves. And why we choose the RV focused apical four chamber view is the dimension of the RV is maximal in this view. So go for RV focused apical four chamber view where you get the good dimension. So first of all, dimension, basal RV diameter, mid cavity RV diameter, RV longitudinal dimensions. So this is 4.2, 3.5 and 8.6. This is routine. And the disadvantage is that RV dimensions are highly dependent on probe rotation by the user. So that is the main problem. Second, you have to go for RA assessment. Always choose the right atrial focused apical four chamber view and do the planimetry. The normal area is less than 18 square centimeters. The disadvantage is that RA area is more time consuming than linear dimensions alone. Then RA pressure assessment is done by assessing the IVC diameter, the approximately 0.5 to 3 proximal to the ostium of the right atrium. Ostium of the right atrium, that is the point where you have to measure the IVC. And you can assess two things, IVC diameter, then IVC collapsibility by a sniff. IVC diameter less than 2.1 with more than 50% collapse indicates a normal RA pressure, whereas IVC diameter more than 2.1 with less than 50% collapsibility indicates the RA pressure is 15 millimeters of mercury. So, and then we come for the RV wall thickness. This is done usually in the subcostal view. Measure the RV free wall thickness. Normal value is less than 0.5. This is important in some of the amyloidosis and restrictive cardiomyopathies where you assess this. Now, RVOT measurements can be done in the LVOT view, long axis, parasternal long axis and the short axis, the RVOT proximal RVOT, and here you can measure the distal RVOT diameter and the PA dimensions. So these things can be measured. The normal is 1.7 to 2.7. The disadvantages is that the limited normative data are available, but you have to measure this. Then coming for RV systolic function, in a non-invasive lab of a basic structure where 2D is only available, you can measure fractional area of change. This is more reliable. It is comparable to the MRI. And the second is TAPSE, tricuspid annular plane systolic exertion, and the S prime. These things can be measured. The fractional area change is in diastolic area measurement, in systolic area measurement. Then you use this formula to calculate the fractional area change. RVC, FAC is normally more than 35%. TAPSE is a slight M-mode placement of the M-mode cursor and referring this should be more than 16 millimeters. The disadvantage is TAPSE assumes that the displacement of the single segment represents the function of a complex 3D structure. It is angle dependent. There are no large scale validation studies. The tissue Doppler imaging, the S prime normally has to be more than 10. It's a very simple measure. This can be used. And RV index of myocardial performance, this TCO can be easily measured from tissue Doppler imaging, TCO, and the ejection time can be calculated. But here, tissue Doppler imaging is much more easier, where the TCO and ejection time can be easily calculated. But the RV strain, the latest guidelines have revised the RV strain. Compared to 2010, where they said RV strain is not standardized. Now in 2025, they have come to the conclusion that RV focused apical window should be used for the cine acquisition, and the inner contour of the RV myocardium should be traced, and entirely the RV should be available. Now there are only 6 segments which can be seen. The RV free wall has 3 segments and it should be more than -20. RV GLS is 6 segment measurement. It should be less than, more than -17. I will demonstrate this in a patient later. RV GLS uses 6 segments, which IVS is part of LV in some of the patients. So it gets confused this thing. So always preference is given to RV free wall strain. So this is how it is calculated. See here, this is the RV free wall 3 segments, then the interventricular septum 3 segments. So both are used. RV diastolic function, similar to LV diastolic function, RV diastolic function can be calculated by placing a pulse to a Doppler at the tricuspid valve coaptation point, and central volume is collected, and then you can take the measurements of E prime, E and E velocity, A velocity, E by A ratio, then E by E prime, similar to the left shot. Now, the measurement of RV diastolic function should be considered in patients with the suspected RV impairment as marker of early and subtle RV dysfunction. And this is called as Lay index or LV eccentricity index, D1 by D2. You can see here. This is D2, this is D1, the measurements, or the D sign. So D1 by D2, if it is more than 1, it is abnormal. Other measurements is mean PA pressure. PA pressure can be measured from the TR velocity, P gradient, and you can have that mean PA pressure can be measured from TR velocity and PR velocity, and then you can have 1/3 of systolic PA pressure plus 2/3 of PA diastolic pressure can be calculated, and the mean PA pressure can be calculated. Pulmonary vascular resistance, this may be important in congenital heart disease patient, and PVR can be estimated using the ratio of peak TR velocity to the RVOT VTI using this formula, PVR TRV max divided by RVOT TVI into 10 plus 0.16. And then from that you can calculate the PVR in OD units. RVDP by DT by the rate of pressure rise in the right ventricle estimated from the ascending limb of the TR using the CW cursor. Measure the time required for the TR jet to increase in velocity from 1 to 2 meters, from 1 to 2 meters, this time interval, and represent in 12 millimeter mercury increase. So this is RVDP by DT measurement can be done. This is mode measurements. Routinely we don't encourage. The paradoxical septal motion indicates the presence of RV volume overload, and it may be present in post-cardiac surgery to ventricular septum in patients with pericardial effusion and in patients with RV. The TAPC and 3D. 3D is very important. This you can see here. RV has the 3 important portions: the inlet, the apical portion, or and then the infundibulum. So these all the 3 can be seen by placing the 3D cursor such a way that you get all the 3 in these images. But even in 3D, if you don't place the probe correctly, the anterior mediastinum, the RV behind that may not be captured adequately. So you have to place the transducer correctly, and it requires expertise. So this is the 3D image acquired from RV focused apical four-chamber view with a frame rate of more than 35 millimeters per second. This is the methodology. Place the TV center and then angulate it. Then place the RV apex, pre-wall, septal, and then you have these measurements which are available immediately. Now we can have some case examples so that now this is a patient with you can see this is a patient with anterior MI. Now this is the LV ejection fraction is around 35%. In these patients, assessment of RV is very important. This is what this is the RV. You can see this is the RV focused apical four-chamber view, and you should not see aorta or the coronary sinus. If you are seeing aorta, you have to tilt the transducer little more posteriorly. And if you are seeing coronary sinus, you have to tilt the transducer more anteriorly. Now I will demonstrate how do you do the fractional area change. This is a simple measure which can be done by any center. You can see here. You stop it in the diastole first, the frames, and this is the end diastole. This is RV area in diastole. Simply planimeter that. This is just a practice session and just drawing that samples. It may not be accurate. Yes, this is the RV diastole. Then you can select the systolic frame. This is the systolic frame. You can see here. This is the systolic frame. End systolic frame. Now you do the end systolic tracing. And you see RV FAC is 38%. It is in the borderline. So RV function is very important for assessment of this. In the same way, you can go for assessment of the RV strain. This is the RV strain assessment. It is very simple. Nowadays, automated systems are available. And see here, you take the RV free wall. They take the RV interventricular septum. This is the apex. And immediately you have that. Then if you process that, it is available immediately. See, RV global strain is minus 7.8. Free wall strain is minus 9.2. And RV free wall strain should normally is more than minus 20. So this patient's RV function is subnormal. And similarly, you can go for assessment of the RV 3D. You can see here, this is the RV focused apical four-chamber view. 3D assessment can be done here. See, this is the RV focused apical four-chamber, and 3D acquisition has been done for this patient. And for this, you can go for the measurements. This is RV quantification software, which are available for advanced models of echocardiography systems, which have this. Now you can go for this, the tricuspid valve center, coaptation point has to be placed, and then the apical, it should be placed in the apex. And then go for the landmarks, set landmarks. The landmarks, this is the free wall, this is the septal, and this is the RV apex. And then this is the RVLV posterior border, and this is the RVLV anterior border. This is the RV free wall. The segmentation comes up immediately, And then it is very easy. So results are immediately available if this is this thing, and you can see that this is the RV inflow, this is the outflow, and the RV apex. So here RVEF is 28.1. So it is very important that to do RV function assessment in patients with anterior MI, LV dysfunction, and here RV ejection fraction is also reduced. It is normally is above 40%. Here EF is only 28%. So that is how you do it in this patient. This is a patient with anterior MI. Then I will show you a case whether now this is a patient with deep vein thrombosis and embolic pulmonary hypertension, severe embolic pulmonary hypertension, pulmonary thromboembolic pulmonary hypertension. You can see here the RV outflow tract is dilated, very easy. You can take measurements here. Then you see the in short axis, you see that the short axis, this is called as the D sign. This IV septum is flattened. Then the D1 by D2 ratio is more than 1. So this can be easily followed. This is the TR. You can see here this is the apical fourth chamber plane. There is gross TR, RV is dilated and hypertrophic. TR velocity is increased. It is around 3.5 meters. So pulmonary hypertension, and this is how it is. So you assess the RV functional assessment in this. So this is a patient with severe pulmonary hypertension. You can see RA is gradually dilated, RV is occupying the whole space. And then you do the RV ejection fraction, again it was reduced in space. So this is how you do the RV function assessment in these patients. And that is in short, this is a case of arrhythmogenic RV dysfunction. You can see here. Case of arrhythmogenic RV dysfunction. RV is dilated, and you can see here. This is RV apex dilated. So these are the types of assessment for RV, and this is all these things I have explained to you. And coming to the final question, thank you very much for your patience here.
Thank you so much, Dr. Amutan. Very nice and lucid presentation of RV assessment with good cases from the Echo Pack. You always do it so interesting. Thank you so much. So we have a couple of questions. Which RV findings on Echo best correlate with clinical outcomes in chronic RV dysfunction or pulmonary hypertension?
That depends on your lab. If you have 3D, always I use 3D ejection fraction. It correlates very well. And then RV strain, especially in high altitude, RV strain is very useful. And in most of the 2D machines nowadays, you have the strain also. So RV free wall strain calculation is very easy, and you can do that. If you don't have, then do the FAC, fractional area contraction, FAC. Both you trace during systole and diastole, that should be more than 35. And simple M mode, that is TAPSE. TAPSE is a simple measure, and if it is less than 16, it is abnormal. So clinically, mode wise TAPSE, 2D, you have the FAC, and then strain, RV free wall strain, and then you have finally 3D RVEF.
So in acute pulmonary embolism, how do you assess and grade RV dysfunction? And does echo guide your decision to initiate thrombolysis?
Yes, in acute pulmonary embolism, the RV apex is spared, and there is a dyskinesia involving the mid RV segment, free wall segment, and that goes by Megdal's sign, and that is very important. You can easily calculate that, and then if you focus on the RV outflow view, where you see the pulmonary artery in the RVOT or in the pulmonary artery or in the left pulmonary artery or the right pulmonary artery, in the branches you can see the thrombus if they are in the proximal segments. If they are in the distal segments, you may not be able to do, but here transesophageal echo will help you. You can do the transesophageal echo where distal RPA thrombus can be identified.
Great. Thank you so much, Dr. Amuthan. Very nice presentation on the RV assessment, a very important topic. And I think all the imagers and all the clinicians should always have reporting of RV in every patient of echo assessment. Thank you so much. So let's move on to the last presentation, a very important topic, again, on strain imaging by Dr. Mahesh Shah. Dr. Mahesh Shah, please.
Where is it gone? It shows internet connection is unstable. Am I audible? Can you see my slides?
Yes,
sir.
yes. Just see.
All right. So friends, we have already overshot the time. I'm going to keep my talk relatively simple. My previous speakers were probably the stalwarts. It was very easily visible or palpable from their talks. My talk will focus on, how a small center like mine can use the recent developments in myocardial deformation imaging in patients with heart failure. And as we know, Dr. Mani had already told us about the limitations of LV ejection fraction in terms of heart failure evaluation. It's primarily a volume-based assessment of ejection fraction and a visual assessment of regional wall motion and regional thickening, which lacks a lot of reproducibility. There are a lot of inter and intra-observer variations, extremely sensitive to loading conditions, and it's quite subjective. In addition, if you have a scarred segment, the adjacent segments would probably become hypercontractile, and the pseudo movement of that segment can be misinterpreted as a kind of hypokinesia of something that is kind of tethering movement. So that cannot be reliably assessed in all centers with all echocardiographers. So though ejection fraction has been classically used in majority of trials for diagnostic, classification, prognostic purpose, and huge amount of data is there, but there is a need for change. And that change comes from our strain imaging. What is strain in very simple terms? If you see over here, the basic, the length of the heart muscle, say if it is 10 centimeter, on contraction, it comes down to 8 centimeter. The change in length is 2 centimeters. So it's a 20%. And because it is shortening, it is known as minus 20%. You just imagine your biceps being contracting lengthwise, it contracts. So the strain is minus in length, and the muscle, because it is non-compressible, the biceps in the mid part blows up. That is thickening of the muscle, and that would have a kind of positive strain. So here we are talking about negative strain, positive strain, and how it is being calculated. I'm going to be brief. I know we are already overshooting the time. So how do we measure those lengths, movements? In echocardiography image, if you see, there are a lot of bright spots. These are the interactions of your ultrasound beam with the structural elements of the myocardium, and these are relatively fixed in appearance, etc., and they can be tracked throughout the cardiac cycle. And throughout cardiac cycle, what is the relative movement of this bright spots, or what we call as speckles? Tracking the speckles, you can assess the strain developing in that heart muscle, how much of shortening is happening. What they do is this is done during systole in the ventricular myocardium, simultaneously shortens in longitudinal segment and in circumferential segment. And in the radial plane, there is a thickening of heart muscle. So these are the three kind of strains we usually assess. They represent X, Y, and Z axis as we see in physics. And there are reciprocal changes happening in diastole. The strain is defined as the change in the length of segment of myocardium relative to its resting length and expressed as percentage that we have already seen in the previous slide. In the broadest sense, you call deformation imaging, which allows more direct assessment of myocardial muscle shortening and lengthening throughout the cardiac cycle by assessing the regional myocardial strain, and over time, how much strain is changing, you call it strain rate. Strain is mentioned in percentage. We are not going to talk much about strain rate. So longitudinal and circumferential shortening is occurring, so that strain will be having negative values, and radial thickening occurs, that strain is in positive. And since myocardium is non-compressible, the sum total of longitudinal, circumferential, as well as radial strain would be 1. It is more complete assessment of myocardial function of the myocardium as such. It is more accurate. It is more reproducible than ejection fraction so far as myocardial function assessment is concerned. One has to understand the layers of heart muscle. If you dissect the heart muscle, it is found to be in 3 layers. There are 2 helical layers, internal and external, which are longitudinal and helical. And middle layer is kind of circular layers are there. This is the schematic diagram. You can see the left-hand helix over here and right-hand helical pattern over here. So subendocardial, subepicardial, and middle layers are the circular layers. Now, because of the helical pattern, the ventricle is going to not only squeeze. When the longitudinal fiber contracts, you have a piston-like movement, compression from in the longitudinal direction. When circular fiber will contract, there is a compression from the sides or from the surrounding sides. But when helical fibers contract, the base is going to move clockwise. If you see from the apex towards the base of the heart, the base is going to contract clockwise and apex is going to move anti-clockwise. So what this will have, this will amplify the effect of ejecting the blood by squeezing motion. If you remember how we dry out a wet towel, not only we compress, but we fold it and squeeze it. So clockwise, counterclockwise movement of base and apex improves the kind of efficacy of ejecting the blood with the same amount of energy being used. Now, what are the implications of this? And of course, this strain is counted in 3 planes, which is longitudinal, circular, and radial. And there are many strain rates available. There are almost 6 types of strain rates. One of them is torsion and twist. We are not going to go again into those details for want of time. Many types of shears are there. We are not going to go into it. Now, how was strain evaluated in the a decade back when speckle tracking was not fully developed? Color tissue Doppler was used for evaluating the strain because velocity gradient, which you can assess, but unfortunately that could be done dominantly and effectively only from the longitudinal point of view. Circular and radial was not that effective. Currently, last decade, the developments have come in the machines and in the processing power and tracking the speckles. The dominantly what is used is 2D speckle tracking. 3D spectral tracking is likely to be the future, but as of now, it is not validated. It is not perfect. We are going to see a comparison slide. And cardiac magnetic resonance CMR can be used to evaluate the strain, which is three-dimensional, angle independent, with a reasonably good spatial and temporal resolution. Sonomicrometry is for to be used in vitro. You implant piezoelectric crystals, and that is supposed to be a gold standard against which the various technologies and machines and algorithms and softwares you can assess. Here you can see the comparison between tissue Doppler, 2D spectral tracking, 3D spectral tracking, and MRI in terms of myocardial deformation imaging. Tissue Doppler, it requires it's a velocity-based Doppler shift. Its only problem is it is highly angle dependent. Being a Doppler, it's highly angle dependent. It's no longer being used as of now. 2D spectral tracking, particularly in the longitudinal plane, that is global longitudinal strain, is something which we commonly use. It is not angle dependent. The spatial resolution is moderate, temporal resolution is moderate, very good reproducibility, very much less operator dependent, and it is widely being used. MRI is gold standard, but it is expensive and time consuming. It is again not angle dependent. It has got a high spatial resolution. Temporal resolution is low because of a huge amount of data which needs to be processed. But I'm sure these things can be improved as the technology develops. 3D spectral tracking, again, it mimics 2D spectral tracking. Only limitation is its temporal resolution is not very high, and very high-end imaging software and hardware is required. So how do you do spectral tracking? It's primarily based on your 2D images. For longitudinal strain, you just take apical 2-chamber, 4-chamber, and long axis views. Make sure that you have a proper views which are not foreshortened. The current generation machine, you also need an ECG signal for timing, and you need to tell the machine where is the aortic valve closer, where is the mitral valve closer. That will help proper timing and tracking. For radial and circumferential strain, you need the short axis views at the apex, at papillary muscle and mitral valve level. And RV strain, Dr. Anantham has already discussed about it. And LS strain, again, you modify use for open up the left atrium in a proper way. Once you have done it, current generation machine, you need to tell where exactly is the ventricle, where it is starting, the anchor points at the annulus and the apex. Rest of the tracking happens by itself. Region of interest, you have to tell the machine, you can adjust the width of the region of interest. You have to make sure that you don't include the papillary muscle, you don't include trabeculae, and you don't include pericardium. And also, if the ventricle is hypertrophied, you don't miss any of the myocardium, because if those tips and tricks are not used, your strain values are going to be affected. I'm not going to talk about radial and circumferential RV strain and LS strain because that is not available widely in majority of machines in small centers. Once those things are done, you press a button and machine does automatical tracking. LV longitudinal plane, the different views, apical 4-chamber, 2-chamber, and long axis views, all 6 segments are tracked, and each line represents the strain of the segment. This is the aortic valve closer, and this is the peak systolic longitudinal strain. We're not going to talk much about circumferential strain, radial strain, or RV strain. And these are the strain rate. Again, strain rates are not routinely used by small centers, maybe for academic purpose, or high-end centers, it might be being used routinely. And the same, here we are talking about longitudinal strain, 4-chamber, 2-chamber, and apical long axis. In each of the view, we are looking at 6 segments, and each segment, what is the strain across time, is being manifested, and it is also shown in a peak systolic strain bullseye map. This is the bullseye map. In each of the segment, how much is the strain in percentage? It is comes written as it is shown in this. You can see all strains are written across. The reduced strain over here, this was a normal patient. Probably you have we have kind of touched the fibrous skeleton of the heart at the aortic ring or mitral ring, and that's why we are getting fallacious ring. This is again one of the technical things which you need to keep in mind. And bullseye not only tells you about the peak longitudinal strain as it is shown in this particular bullseye, but it also tells you about time to peak. Now, time to peak is very important to understand in patients with dysynchrony, where each segment might be reaching the peak at a different levels, or in patients with ischemia. In ischemic segments, there is a delayed contraction. So beyond our aortic valve contraction, there is going to be a delay. So here, probably in this area, you can see the delayed contraction which is happening. Post-systolic index will tell you how much areas have a delay, and that calculates the index which is useful to detect ischemia, etc. This is right ventricular strain. Professor Anantham has already discussed about it, so we are not going to go into these details. This is left atrial strain. Again, not easily available in small and medium range centers. Now, let us understand very clearly why GLS is far better and sensitive than ejection fraction to evaluate the cardiac function, left ventricular function. You remember the layers of the heart which I said, and the inner layer, the subendocardial layers, are the longitudinal helical fibers. If you see the cardiac supply, blood supply, by the time the blood reaches the end, near the endocardium or the inner layers, the capillary pressures are much lower as compared to what pressure is there in the epicardial artery. So blood is coming here at a much lower pressure. On top of that, the cavity pressure is high, particularly during systole. So this subendocardial areas are more prone to ischemia. And similarly, in patients with hypertrophic conditions, again, there is a paucity of vasculature, paucity of blood supply over here, and more early affection of the inner longitudinal fibers. When inner longitudinal fibers are affected in an early phase of any disease, what happens is your circular fibers will get hypertrophied. They will compensate for loss of function of the inner fibers, and hence your ejection fraction will be fallaciously normal despite early affection of the left ventricular contractile function. And in this left lower corner, you can clearly see global longitudinal strain does not correlate with ejection fraction. Even in seemingly normal range between 55 and 60, you can see a sharp drop in GLS. So GLS is more sensitive in picking up subtle and early left ventricular dysfunction as compared to ejection fraction, or even global circular strain. Your circular strain also, it correlates with ejection fraction because that is one of the late to be affected. Here you can see in people with different levels of wall thickness from 0.5 to 2.5. This side is 0.5, this side is 2.5 for the same ejection fraction. In an hypertrophic ventricle, your GLS comes to be on lower side. So that clearly depicts that GLS is far more sensitive than ejection fraction. Now coming to the clinical scenarios where it can be useful, there are pathological conditions characterized by marker dysfunction despite preserved ejection fraction. Like say, for example, if you have a patient, family member of an hypertrophic cardiomyopathy is an asymptomatic carrier, or early in life when hypertrophy is still not developed, you'll find that the GLS is abnormal. Sarcomeric mutations, Fabry's disease, myocardial steatosis, Duchenne muscular dystrophy, all those diseases in early phase, it can help you detect it. On top of that, in valvular disease, evaluation of the ventricular function is difficult in, and sometimes by the time ejection fraction starts falling, it might be too late to intervene, particularly when we have easier and lower risk percutaneous procedures which are available. In aortic stenosis, in aortic regurgitation, mitral regurgitation, GLS tells you and at an earlier stage. Of course, a lot of validation is required, a lot of clinical data is required before it can be widely applicable. But there are already current generation data that are progressively, sequentially, if you are following the patient, if there is more than 10 or 15% fall in GLS, then probably that is the time when early ventricular dysfunction is setting in, and you should evaluate the patient thoroughly for indication for intervention. In case of coronary disease, global strain values are obtained early after acute MI may effectively predict subsequent remodeling and functional recovery. Now, these are various hypertrophied ventricles, and you can see the examples on left top. A is your asymmetric septal hypertrophy. You can see the regional strain has been affected and apex is relatively spared. Apical hypertrophic cardiomyopathy, where apical regions, the strain is very affected, and basal segments and mid segments are progressively less affected. In amyloidosis, the picture is shown as cherry on top. Overall, GLS is reduced, but apical preservation is there, which is very typical of amyloidosis. In Fabry's disease, again, there is a reduction in global value, modest plus focal areas. In arterial hypertension, again, you can see the overall there is a reduction plus some more reduction in the septal area. While in an athlete, despite having hypertension, many times athletes have some ECG changes. They do have significant left ventricular hypertrophy, bordering to the diagnosis of hypertrophic cardiomyopathy, diffuse variety. But when you see the GLS, it can easily tell you that this gentleman is does not have a disease, and he can safely go ahead and develop his career as a professional athlete. So GLS, which is the most commonly used parameter among the deformation imaging, it picks up preclinical disease before the overt heart failure sets in. The longitudinal deformation likely reflects impairment primarily of the subendocardial longitudinal fiber bands, and circumferential deformation is probably a late development. That is when your ejection fraction starts dropping. We already saw it in one of the earlier slides. Alteration in ventricular twist would again probably be seen in an earlier deformation, unfortunately not available in many small and mid-range centers. The greater disc synchrony have been observed in setting of many conditions predisposing to overt heart failure. Advanced age, hypertension, diabetes, renal insufficiency, obesity, atrial fibrillation, and particularly in oncocardiology, chemotherapy and radiotherapy related LV dysfunction can be easily picked up at an earlier stage. And of course, in HFpEF also, it has been discussed by my previous speakers. In cardiac resynchronization therapy, regional delays or time to pick, it might be able to give you the idea about which areas to put your lead on, focus your lead on onto the lateral segments. This is before CRT, and after CRT, you can see there is a lot of dyssynchrony, septum, lateral wall, and work difference. While after CRT, it helps you not only to place the leads, but also programming the patient CRT to find out the subtle changes in dyssynchrony. This slide clearly shows post-systolic shortening as happens in patients with myocardial ischemia. This particular segment is ischemic. I'm not going to go into the details. And in left bundle branch block, again, you can see the kind of dyssynchrony which is there. What are the limitations and challenges we face in myocardial deformation imaging? There is an inter-vendor variability. You take a GE machine, you take a Philips machine. GE machine has 2 percentage point on a higher side. Philips machine shows it on a lower side, because they are using different proprietary algorithms to detect and track and calculate various values which are coming. There is a lack of standardization. There is lack of normative data for age, gender, and ethnicity. So a lot more clinical research and epidemiologic studies need to be done, and the studies in disease situations. And there is a huge data overload. The kind of normally, people are used to ejection fraction. Echo kiya, how much is your ejection fraction? Now, for deformation imaging, GLS, yes, it can replace ejection fraction, but there are too many parameters. There are 3 different strains. then strain timing, strain rate in systole, in diastole. So almost 9 values are generated. Which one to focus on? Which one is important in a given clinical scenario? That becomes quite overwhelming, and it can confuse. And on top of that, large number of these parameters, they go hand in hand. If one is affected, other also is affected. So which one particularly is most important need to be understood. But majority of parameters would highly correlate with each other, and focus on the parameters most closely associated with clinical outcomes. And as of now, GLS is the one which we need to follow. There are few tips and tricks you need to keep in mind. One is you have to have for optimal speckle tracking, the frame rate should be between 40 to 90 frames per second. Low frame rate will associated with loss of speckles, loss of accuracy, because some of the speckles are going to move out of the frame, and high frame rates can lead to a lot of noisy signals which may be difficult to smooth. You need to give ECG signal as at least in older systems, but the current generation systems or machines which are available, they are AI based. They not only don't need an ECG signal, they can time the aortic valve closure, mitral valve closure, endocardial border, the thickness, etc. And of course, you need to avoid premature beats or irregular rhythm. If the patient has occasional premature beats, the clips which you store, they should not have those premature beats. Otherwise, the results are going to be degraded. A very good quality echo visualization is required, particularly in lateral segments. It's very important. Region of interest the width should cover the myocardial thickness, avoid pericardium, avoid papillary muscles, avoid cavity, avoid trabecula, and avoid the valvular rings. And you need to time the aortic and mitral valve properly. If you have not done, what happens? These are few of the examples. Non-standardized echocardiography is used, foreshortened view, and you may have a falsely elevated GLS. This is for RV. Hypertrophic LV, if you don't cover the full thickness of the muscle, your GLS might be erroneous. Similarly, if you don't include all the contours of myocardium, you may have problems. And if you do not time the aortic valve closure properly, again, if you have not marked it properly, then it will affect the final calculated values. Cardio-oncology is one of the very important area of cardiology where GLS is very commonly used, because many of the oncotherapeutic agents or chemotherapeutic agents which we use in early phase, it might show a subtle LV dysfunction. That is the time you need to stop, you need to modify therapy, you need to delay the cycles till it recovers, or you need to cover the patient with pharmacotherapy with a wishful thinking that, the heart failure therapy is going to prevent it. But if there is a significant LV dysfunction and if it is missed in the later time period, next few months or years to come, the mortality can be worse than the cancer which is not treated. And that's the reason why all our oncologists are extremely finicky. Before every cycle, they would ask for a GLS. On ejection fraction, if the fall is more than 10% from the baseline value, is the time where you need to modify your therapy, delay your therapy, or change your therapy. And for GLS, it is the 15% drop from the baseline value is where you would start becoming cautious. These are few of the chemotherapeutic agents, their mechanisms of cardiotoxicity, and what are the incidences of LV dysfunction. And the LV dysfunction is graded. And of course, symptomatic chemotherapy-related cardiac dysfunction and asymptomatic gradations and classifications are available. So friends, to sum up, strain imaging is something which we need to embrace with the wide arms. GLS is ready for prime time, and there are many other parameters which are not easily available. What I would like to point out is with the advent of AI, in the medical imaging section, it is replacing a lot of efforts. Like what RV strain, what Dr. Anantham showed. He had to transfer the data to EcoPack, then identify RV. Here with the AI based, there are systems which are US FDA approved. You just have a contact with them, you have a contract with them, you upload the data, and within 5 minutes, majority of your echocardiographic parameters are all measured, identified, and done. You don't even need to give an ECG signal. It will identify systole, it will identify which views are there. You don't need to label even the views. And I have taken a demo of around 40-50 run-of-the-mill patients, not selected good quality images patients, and I was really impressed. And there are many such coming. They have trained their AI database by 35 million echocardiograms and strain rate, left ventricular strain, GLS strain, all three types of strains, RV strain, LS strain, and all parameters, interpretation, everything is ready within few minutes of uploading the data. Thank you very much, friends, and I hope it was worth your time.
Thank you so much, Dr. Mahesh Shah, for an amazing talk and discussion on strain imaging. Yes, it is ready for prime time, and we are already using it on a day-to-day basis. So a couple of questions for you. When would you recommend strain imaging in HFpEF?
In my opinion, HFpEF, we don't have very great parameters for diagnosing HFpEF, putting in the severity, etc. But when HFpEF is bordering towards the normal ejection fraction, lower limit of normal ejection fraction, that is where subtle LV dysfunction, you can pick it up, and probably these are the patients, because in HFpEF lower side ejection fractions, we have found that foundational therapies are working very well. So these are the group of patients where I would find it to be useful. I would prefer to do a GLS in almost every patient with HFpEF and following him up, just like we do the markers periodically. I would like to do it in practically every patient sequentially.
Yeah, so I think I would like to add that we have to do it on a regular basis to all patients, because there are entities, and this comes from a paper where you have HFpEF with reduced GLS and also HFpEF with preserved GLS. So if in HFpEF if you have LV-GLS is normal, then you start looking at a condition called primary atrial cardiomyopathy. So the answer is you have to do it in every patient.
True.
Now, second question, does DLS help in differentiating constrictive pericarditis from restrictive cardiomyopathy?
I don't think we have a large amount of data for constrictive and restrictive cardiomyopathies. I think we are going to go more from Doppler parameters, etc., to differentiate those conditions.
Yeah, okay. I think I'm sorry to differ. So this is again coming from Parthu Sengupta's paper. So in restrictive cardiomyopathy, you have the GLS going down, while in constrictive pericarditis, the GLS is normal, because it is the circumferential strains which get affected from outside. So the subepicardial fibers comes up. So this work came in Nature, and I think you can go and read about it. So I think we had a phenomenal discussion from Dr. Mahesh Shah about the strain imaging. And let me just conclude in telling that it is very much reproducible, and a recent last paper which showed about the intervendor variability was 3.3%, but now a recent paper came 15 days back that the intervendor variability has now been reduced to 0.6%. So it is a very robust parameter and should be done on a routine basis. And there are, as I agree with Dr. Shah, that the AI has come up, but all you need is a good imaging. A 2D imaging should be done very properly. Now, I'm slightly worried about the 3D strain, because it has not seen the future, but there are some reports going on about what is going to be the future. So let's not comment on that. So I think all the speakers have done a very good discussion and justice about all the topics. So over to you, Khushbu or Raksha, anybody? You had Mansi, yeah.
So, sir, I would like to project the poll questions. So we
Okay.
have asked this question after each talk. So this was the first question. So in borderline LVEF cases, which additional echo parameter would you like to use the most? So most of the audience more than approximately 60% audience, they have voted for the GLS option. Sir,
Yeah.
we have more than 1300 audience. So
Wow.
we are taking the responses from 1300 audience. Next question was on which diastolic parameter do you rely on most when evaluating HFpEF patients? So more than again 60% patients, they have voted for the E to E prime ratio, followed by the two options, mitral inflow pattern and tissue Doppler. Third question is on what is your go-to parameter for assessing RV function in your clinical practice? So most of the audience, they have voted for the TAPSE option, followed by RV fractional area change. And the last question, what is your main barrier to routinely use strain imaging in clinical practice? So most of the clinicians, they have voted for the lack of equipment or software, and 25% voted for the limited expertise. So I think after this Dr. M.K. Shah's talk, their knowledge on the barrier or the strain technique have been improved. So thank you, sir. Thank you, Shah sir.
I think the poll
Well-
questions were really nice. We get a perspective that what is the need of the future. So I think they need more training on the strain imaging. They're interested, and also I think the equipment should be there. So that's the key.
Yes.
So I would like to just add one point. Even if you have 10, 15, 20-year-old equipment, so far as it gives you a good quality 2D images and you have a DICOM output, you don't need to change your machine. You just hire one of those AIs which are US FDA approved. They are working with American Society of Echocardiography, Harvard, Massachusetts, etc. And their validation also is done, and it is a US FDA approved also, and it's very cost effective if you are ready to spend maybe 150 bucks per study, and you can get the parameters of all newer generation machine. And again, you don't need to keep changing machine every few years just because the company now introduce a little bit of AI feature here and there and sell the old machine at dirt cheap. With the same machine, this software will keep on improving. You don't need to change or upgrade.
Absolutely agree with you. Absolutely
Yeah.
agree. Great. So I think it was a good discussion, Mansi.
Yes, sir. So, sir,
We can end.
Yeah, can you give, sir, closing remarks?
Okay, so I think the closing remarks, I think I absolutely agree that the strain imaging is going to be there. But I think before doing strain imaging, a good 2D imaging is mandatory. And please don't forget using an ECG, because ECG is mandatory. And if you do a good image and continue with the protocol of having all the parameters of LV, LA, and RV, along with the E by A and the E by E prime parameters, you're not going to miss anything. So I think echo is a robust marker, and one echo may not be sufficient. A serial echo is very much needed, including in ICU and in the follow-up of the patient. And it should be supplemented by good, astute clinical knowledge and biomarkers, as what Dr. Samesh Srivastava had added. So I think we are all clinicians to start using it. And if you have any doubts, please don't be frightened to ask any of us. We also have many times doubts. Keep on asking us. We'll be happy to answer. And thank you so much, everybody. It was a great discussion. It tells you that people are hungry of knowledge. And thank you, Glenmark, for having this session. Over to you, Mansi, please.
Yeah, thank you, sir. So I think this is an opportunity to thank everyone, Dr. Sen Gupta, sir, to all the speakers, Dr. Shah, sir, Dr. Mani, sir, Dr. Amuthan, sir, and Dr. Srivastav, sir, and whose expert guidance and in-depth knowledge and patient teaching made this session both insightful and practical. So I would like to thank my sales team, my marketing team, technical team, and Blue Ocean team for the smooth execution of this training. And to all the audience, thank you for your very interactive questions, very thoughtful questions, and your eagerness to learn is what made this session very interactive and successful. Lastly, we hope this training has not only enhanced our technical skill, but also deepen our clinical understanding on 2D echo, the echocardiography. So thank you once again. Thank you so much, sir. And we are looking forward to see you in further sessions. Thank you.
And
sir.
just like to add
Thank you,
that
everyone.
we will like to have everyone of you, all the attendees in Kochi from 18 to 21st September for
Yes.
Echo India, where all these faculties will be there. They are our backbone, and it's going to be a great learning experience, networking experience. So please be there in Kochi from 18 to 21st September for Echo India. Thank you, everyone.